Charles Raison. I'm on the steering committee for the U.S. Psychiatric Congress. I'm here with Dr. Stephen Sowell. Good to see you.
Good to see you, Chuck.
So, you gave a great lecture about obsessive compulsive disorder last night. Talk to us about some of the challenges with exposure response prevention therapy.
Exposure response prevention therapy is a therapy we all can do. It does not take a tremendous amount of time. It's something that psychiatrists can do within the context of the appointment time that they have with patients. The concept, very simply, is that you encourage a patient, cajole a patient, push a patient to expose themselves to the issue that scares them. If the fear, for example, is contamination, you start off by doing it in their imagination, in their mind, allowing themselves to go to a public restroom, use the facilities, touch the doorknob, etc. And then you start to do it actually in vivo, in person, live. And the key is to not do the behavior that they believe they need to do in order to prevent the dreaded outcome. So you prevent the response. And the concept is that by doing so, the anxiety that they have when they're exposed to the stimulus eventually ameliorates. And they begin to recognize that they don't have to do the behavior. The pitfalls are as follows. Number one is starting off by immediately having the patient flood themselves with the stimulus itself. It's overwhelming, patients can't do it. Number two is you have to start with the imagination part. Number three is you have to do it in a hierarchical process, starting with the part that's least scary and going to the stimulus that's most scary, but you have to get all of it. You have to get all of it. You can't leave something that's a big fear, because then the behavior will start to come back and progressively move to less and less fearful situations. And then one mistake that a lot of psychiatrists do is they sabotage the entire treatment because they prescribe benzodiazepines. Mm-hmm. So a patient is in the anxiety-provoking situation, and they take a benzo in order to decrease the anxiety, and they get less anxious. And what do you suppose they attribute the decrease in anxiety to? The benzodiazepine rather than the therapy process. And consequently, the whole treatment gets sabotaged and doesn't work.
They just grab onto the benzo and
they just grab onto that PRN benzo, and the whole treatment has been sabotaged. So it's really important to avoid PRN benzos when doing ERP in patients that have OCD.
That's great. Thank you so much. Fascinating.
My pleasure. Thank you.